In today's class, I shall be dealing with the autopsy and grossing of the heart and the great vessels. Part 1. Please follow it. It is part 1, which means there is a part 2. And I would advise you people kindly not to miss R.A.T.S, the UG classes. This particular presentation of mine is dedicated to my teachers, and the sources of references to which you people are free to go shall be Robbins, Ludwig, Otto Sapphire, Vagoliker and Langever, Autopsy Practices, the book by Dr. Langever, R.A.T.S in Pathology, my channel, and my personal experiences. Here, I am seeing a boat-shaped heart, classical of the tetralogy of Fallow. Such things we should be having in mind when we are dealing with the pediatric autopsy. The giant and the gentleman behind this presentation, Ludwig. He has contributed many things, but in this context, this is the sentence I would like you people to kindly follow. The pathologist knows everything, but always a day too late. A very classical and controversial saying by Ludwig. In today's topic, there shall be various highlights that we shall visit. These are assumptions and not actuals. You are free to realign them in your own way and reword them. We shall be talking about the anatomy, the development, the anatomical landmarks, and the various parts of the heart, including the pericardium, coronary arteries, chambers, and the valves. Also, we shall be concentrating on the methods of opening the heart, the significance in each region. The lesions can be found chamber-wise, valve, and disease-wise, measuring where to take the bits from and the pictures. Of these, this is something that will be not harassing us, but a constant battery of questions. Opening the heart, what are the various methods? And secondly, when we do answer, whether it is a specimen or the autopsy, these shall be asked. The lesions shall be chamber-wise, it can be valve-wise, it can be disease-wise. Always when the topic is too long and complex, it is better to have subheadings. These are the subheadings that I had prepared, and the Roman numerals are mainly for my own sake, so that I would be able to align them in the correct order. I would like you people similarly to prepare your own list. Do not follow the lists of anybody else, including mine. Your list is the best list. Coming to the anatomy of the heart, the shape is pyramidal. Sometimes it can be more ovoid or bulging. 12 to 13 centimeters will be the distance from the apex to the base. I shall tell you what the apex is, what the base is. The weight of the heart, always the males have a larger heart. Maybe they are more magnanimous, but not really. 300 grams. Females, it is 250 grams. Roughly, it is about the size of a closed fist. And as I had mentioned in the earlier slide, there is a right side of the heart, left side, the great vessels, pericardium, valves, bundle of discs, septae, and aorta mitral curtain. These are all some things that we people should be remembering, and repetition is the mother of knowledge. That is why I am doing so. Coming to the congenital heart disease, the source of this particular slide, the text is from Ludwig, and this is from the net. What I am seeing is a dextrocardia. A dextrocardia can be independent or it can be aligned with absence of the frontal sinuses as well as loss of ciliary motility, which will be the cartilaginous syndrome. And these are the hallmarks to be followed. Normally, we get Latin words and Greek words, but there is a nomenclature in which we should use the English words or the anglicized words. There should be an en bloc dissection when you are suspecting a cardiac or a cardiovascular or a cardiopulmonary pathology. If it is going to be a pulmonary hypertension and death, that can be symptoms of right heart failure. Cardiomegaly, we will see what it actually means. There can be abnormalities of the coronary arteries and conotruncal abnormalities. Let us see what this particular term means in the later slides. So, for congenital heart disease, we people should be using anglicized words instead of the Latin words. And before I plunge into that, what is the development of the heart? The development of the heart is otherwise called as cardiogenesis. There are two endocardial tubes. The heart itself is a tubular structure, and in which we have got a bulbous cordis, the ventricle on the top, and the atrium below. So this is the primitive ventricle and the primitive atrium. During the process of embryogenesis, it twists upon itself such that the atrium goes to the top, the ventricle remains status quo. And from this, we have got the truncus arteriosus, which can later on become the aorta, and the sinus venosus, which can pave way for the vena cava. Now let us go to the development of the heart. It is a crescentic structure, and there is a medial ridge called the conotrunkus, from which you get the ventricle and the atria of either side. These get fused together and form the ventricles as such, the right ventricle and the left ventricle, and also you find the atria are lower down. And when there is going to be a bend of the heart, you find that the atria ascends the structure. This conotrunkus is of great importance because when there is a rotation and when there is a fusion, failure of it can lead to dextrocardia or a septal defect, or sometimes a common artery arising out of the right and the left ventricle. This is what I mentioned. So you find again there is a fusion of the atria and there is a bend of the heart. The ventricle lies lower down and the atria ascends to the top. And you find that there are two structures that are originating from it: the pulmonary artery and the aorta. This is the development of the heart. You need not go to the complete embryogenesis, but it is important and pertinent for us to know this. This is the various abbreviations. You people can kindly follow these diagrams, which I have sorted with great pain. The heart itself is some kind of a fibrous skeleton. That is why it does not collapse like an intestine, in which you find all these structures. I am not going into the chambers. There is a groove between the atrium and the ventricle and between the ventricles themselves. And there are the various structures that are there. There is something called an atrial appendage and a left atrial appendage. The left atrial appendage will be important for sampling. So this is again the embryogenesis. You people will be remembering. It is a primitive heart. But in the primitive heart, there are certain things. For example, there is a septum primum. There will be a septum secundum. These will have to fuse together. Otherwise, there will be a septal defect. Similarly, you find that from the inferior region also a septa develops, dividing the ventricle into the left and the right chambers. There can be the opening of the sinus venosus or the vena cava. And there will be multiple ridges and nodules that can be seen in the heart, which we will have to identify. Developmental anomalies. There are a lot of developmental anomalies, but we, for the time being as pathologists, we need not be as perfect as the anatomist or a pediatric surgeon. We should know that there can be septal defects. There can be a patent ductus arteriosus connecting the aorta and the pulmonary artery. Dextrocardia we have already seen. A patent foramen ovale is also a form of a septal defect which can lead to lack of support of the mitral valve, leading to a floppy mitral valve or sometimes a paradoxical embolism. These things are given well in your Robbins. Paradoxical embolism can be a definite question that we can expect. And this figure shows a septal defect which has been identified by means of a probe. This is a forceps that is used for keeping the ventricle apart. How do you remove the heart at autopsy? First, the sternum is removed because the heart is substernal in location. If there is going to be an adhesive pericardium, the adhesions are released. And if there is going to be a hemopericardium, you will have to remove the blood and then weigh it. If it is going to be purulent material, it has to be sent for culture. These are of extreme importance for us to make a diagnosis. There are different methods of removing the heart. The heart can be individually or independently removed. And if there is going to be some other lesion like athyroma of the aorta, then it is done along with the other thoracic organs. Or if there is going to be a esophageal malignancy and an adhesion, we will have to remove it, what is called as en bloc. Normally, in an individual less than 30 years with no cardiac pathology, it is removed individually. If you suspect any cardiovascular or cardiopulmonary pathology, better to remove it en bloc. And please be careful, this is the method of removal, not the method of opening the heart. This is what we people see. The lungs have been removed, the heart has been left in place, in which I am able to see that it is covered by a fibrous pericardium. Also is seen a laryngeal nerve at the side. So when there is going to be a cardiopulmonary death, then the reflection of the aorta and the inferior vena cava onto the thoracic side is mandatory. This is the system followed by Rokitansky. And finally, an en bloc removal is done. Weighing the heart. So after having separated and cutting the great vessels as close to the heart as possible without damaging them, we weigh the heart. And as I mentioned earlier, the blood will have to be removed before we do the weighing. Normally, it weighs about 0.45% of your body weight. In the male, it is 300, and in the female, it is 250 grams. Coming to the size of the heart, it can be a large heart. Cardiomegaly. Different causes are there. We will be seeing it later. It can be a small heart. Constrictive pericarditis, a cardiac tamponade. All of this can be either moderate or severe. And finally, you have a normal heart also. And this kind of an enlargement or a decrease will be based on the region that is affected. Also, people should remember that there will be a rigor mortis that is setting in, which will be changing the size of the heart. So you people should be fluent and deliberately answering the examiner. So size of the heart, do not be blinking at them. It can be normal, it can be large, it can be small, and you continue with your thing. And how do you measure the heart? It will be one along the long axis. Two, you people will have to take the diameter, the short axis. This will be the diameter of it. And then the formula that is to be followed is pi into 2 by 6. 2 is supposed to be the short axis and 6 is the long axis. This is the formula that you people should follow for measuring the heart. The shape of the heart. It can be conical. It is usually conical. We have seen a couple of pictures. It can be irregular, as in the case of an ventricular aneurysm. There will be a bulge. It can be boot-shaped, as we had seen earlier, a tetralogy of Fallot. It can be banana-shaped, as in the case of cardiomyopathy. So they might ask you, is there any variation in the size, shape, etc.? Coming to the color, you find it will be pale in the case of old infarct. And in the case of a recent infarct, it will be more reddish, unless the infarct is resolved. It will be pale and waxy, slightly enlarged in the earlier stages in amyloidosis. And it can be appearing hemorrhagic in the case of cardiac tamponade. The consistency is 1. Generally, it is firm. It can be in the case of cardiomyopathy or in the case of fibrosis. Calcification, rigor mortis, all of this can lead to a firm heart. Soft in the case of necrosis and decomposition. So please do remember these things. What is the size of the heart? What is the weight of the heart? What is the color of the heart? What is the consistency of the heart, etc. So this is one. So this is a heart in which I am finding yellowish white or yellowish gray exudate as patches. Obviously, it is a kind of a purulent exudate. That is why great care must be taken when we open the outer layer of the pericardium, aspirate the pericardial fluid, and send it for culture. Sometimes you find that the heart itself is very loose. It collapses. We call it a flabby heart. It can be in a case of diphtheria, where there is a defect in carnitin, a cofactor that is formed in the case of diphtheria. And coming to the different parts of the heart, before we do open up, the first thing that we will have to do is to reflect the pericardium. The pericardium can be reflected by means of an incision and then gradually separated. In fact, it should peel off on its own, but it gets adherent in the case of a pericarditis. And in this particular case, I am finding that it is not transparent. Normally, you will be able to see the underlying structures through the pericardium, just like the pleura. But here, it is opaque, thanks to the pericarditis and fibrosis. There might be different types of effusions, a serous effusion, seropurulent, or there can be a hemorrhagic effusion. Sometimes there can be what is called as a constrictive pericarditis, and there can be a cardiac tamponade also. If you are lucky, we shall be seeing a couple of pictures of this. These I have removed from the dissection of the heart, a beautiful series if you people can lay your hands on. So in the pericardium, we should look for the opacity, the overgrowth of fat, fibrous, serous or hemopericardium, cardiac tamponade, a soldier's plaque. Soldier's plaque is an organized fibrinous pericarditis that is seen as a badge on the heart itself. And it is described so. It is as though a soldier is wearing a badge on his chest. These are terminologies found in the earlier editions of Robbins. Nowadays, you might not find them there because of want of space. And this is one of the complications of a myocardial infarction, a cardiac tamponade. Here, there has been an attempt to separate the parietal layer of the pericardium, but the visceral layer is sticking on. And I'm able to see multiple strands of this, which is a classical bread and butter pericarditis that you see in a rheumatic heart disease. And the sources are the pericardial disease, brown med over here. I have not removed these words because the credit goes to these people for providing us with wonderful material. Now, so there is a difference between method of opening the heart and the method of removing the heart. They are two different things. Obviously, we will open the heart after it is being removed. Look at this one. It is not a simple answer. There are multiple an entire plethora of lists that is there, which I would like you people to kindly by heart. By heart, there is no other word. Is it clear? So these are the different methods. If you are not happy with the list, see this also. So the entire list you people should be rattling off. And if your examiner asks, where did you read this from? You boldly say it is from Ludwig, Autopsy. And Ludwig himself says, in spite of this entire panel, these two things which I have underlined are logical. One is the inflow-outflow method described by Rudolf Virchow. And the second one is bread loafing for finding out any obstruction in the coronary artery. There are all the other methods which you people will have to by heart beyond my explanation. Coming back to the opening of the heart, so one structure I definitely know will be the inferior vena cava and the superior vena cava and the inferior vena cava. These are perpendicular. So what I do is I keep these straight. The remaining heart falls in place. So when you are asked to show the anatomical position of the heart, this should be it. And there will be a slight tilt in the apex of the heart. This is the base of the heart. This is the apex of the heart. This is the coronary sulcus in which you find the coronary artery. And when I go posteriorly, I find that there is a left atrium. The left atrium, there will be a couple of veins which come into it, the pulmonary veins. Those also are being probed into. And this is the probe between the superior vena cava, inferior vena cava and the superior vena cava. And care should be taken because when you do put a probe, you will be dislodging a thrombus. And sometimes it can be a malignant thrombus arising from a renal cell carcinoma, entering the renal vein, up the inferior vena cava, going up to the right side of the heart. That is why caution should be there. And this is a transverse sinus. Look at the dissector. Yes, put in a digit of his. There is a plane of separation between the great vessels and what is behind. This will have to be taken into account. Also, people used to ask, where is the coronary ostia? Immediately after the aorta comes out, the first group of openings will be the coronary ostia, from which we will be getting the coronary arteries. Sometimes it is described as the sinus of Valsalva. In the next few slides, I shall be showing you magical pictures of opening the heart. But before that, I would like you people to kindly by heart this list. This, I created my own mnemonic, the rule of 3. There should be 3 incisions on the right side, 3 incisions on the left side. First will be the right side. It has been mentioned that it should be in the direction of blood flow. So the lateral part of the right atrium is open in between the vena cava, and we can inspect the right atrium from within. After which, the lateral side of the right ventricle is open. The third incision shall be from the right ventricle up to the pulmonary artery, close to the interventricular septum on the right side. Do not damage the septum. And we are also not supposed to damage the valve cusps. Similarly, on the left side, as I showed you earlier, there will be the pulmonary veins. These pulmonary veins are opened up and the lateral side is being cut so that you can see the left atrium from above. You will be able to find some abnormalities. Also, you can look into the mitral valve. Similarly, you find that on the left lateral side of the ventricle, you will be putting an incision so that you open the ventricle. Once the left ventricle is open, you will have to pertinently cut through a part of the left ventricle going into the aorta, maybe through one of the cusps and opening the aorta. But as far as possible, we should not be damaging the valve leaflets. And also, you people should not be damaging the papillary muscles. Y is missing over here. And the caudate tendinae. Look at this one. Initially, as I mentioned earlier, the right atrium and the right ventricle. The right atrium is opened up and then the right ventricle is also seen below. One thing I would like you people to appreciate is you find that there is a lot of these foldings and ridges, which makes this different from the left side. The left side, you find it will be a little more bland. I'll have to look into the pulmonary artery and the tricuspid valve, and finally I will have to open it up. And when I do open, I'll be finding the pulmonary artery over here. So I look for any of the abnormalities. It can be acquired, it can be congenital. So the right side of the heart is open. The next will be between the pulmonary veins. I put an incision, open up the atrium. And also I'll be cutting along the lateral border of the ventricle so that I'll be able to see the mitral valve over here. And also later on I cut through the ventricle, I go into the aorta. So that the aortic valvular cusps I'll be able to see, I can examine the ventricles and also the chordae tendineae and the papillary muscles, the thickness of the ventricular wall, etc. So this is the classical and the most logical method of opening the heart, the direction of flow of blood. And who said this? It is Rudolf Virchow, the father of pathology. And when we do all this, we'll be able to see multiple structures. As I mentioned earlier, there can be a fossa ovalis, which can be a remnant. There can be a membranous septum, which grows into a complete septum. There can be a sinus or an opening for the coronary artery immediately after the aorta opens up. And these are the leaflets, which are somewhat feathery, transparent, allowing light to pass through. The tender papillary muscles and the chordae tendineae. Sometimes there can be a little bit of a pericardial fat. See the amount of volume that I can gather from the single picture. And this again, you people can restructure, superimpose. This is from the Gray's Anatomy. So I would like you people to kindly appreciate it. These are the things that you people see when we open up the heart. Once again, I summarize. Right side of the heart is open. Between the vena cava, there is a incision, and I will be able to look at the tricuspid valve, find out if there is any damage to it. Then the lateral border of the right ventricle, and finally through that the pulmonary artery is opened up. And on the left side, again the left atrium is open. Open up the left ventricle, examine the mitral valve from above and below, and then open the aorta. Look at the cusps of the valves. And coming to the valves as such, measurement of the heart is one, measurement of the valve is another. A common question that is asked, and even otherwise it is common sense for us. How do you measure? It can be done by means of a string. You don't have any instrument in your center, just a piece of string which is around the valve. You will be able to get the circumference. Otherwise, there can be a graduated cone. As it goes deeper, you find according to the graduation, you will be able to make the measurement. And the thickness of the valve leaflet can be measured by means of a vernier caliper. This, of course, is my own innovation. Because sometimes they say there is a thickening of the valve. How do you say that the valve is thickened? How do you measure it? Probably we can use a vernier caliper. Coming to the function of the heart, it is somewhat difficult to assess at autopsy, because the patient is no more. Now I cannot say that this is the reason, but still Ludwig, he goes forward and says, if there is going to be an incompetence, you find that this can be made a diagnosis of by pouring water. If it is incompetent, it will be going into the next chamber. And stenosis means you find that there will be a smallest area that has to be measured, which is the stenosis. And this is a cone that is used. Look at the graduations over here from which you'll be able to make a measurement. And these are various probes which can be used for finding out the pathology in the blood vessels. It can be arteries or it can be veins. I shall be describing them later also. but we should be careful that a thrombus in it or a thromboembolus should not be dislodged. So this is a normal heart in which I am able to see the valve leaflets from the top. In this case, it is a mitral valve here, but then it is bulging into the left atrium instead of remaining in place. A classical case of a floppy valve syndrome, which is supposed to be diagnostic of Marfan syndrome. So please do remember these things. I think you'll become a stalwart in cardiac pathology. And this is the formula that can otherwise be followed. You don't have a string, you don't have a cone. Okay, you can at least measure the radius. And once you know the circumference, this will be it. Even if you have a diameter, you'll be able to make a measurement of it. Now, what is the significance of grossing the heart? I have compiled my own list over here. From the pericardium, what do you see? From the external surface, what do you see? Inferior vena cava, the tumor that I said. Renal cell carcinoma. Ascending aorta, sometimes we can find a saccular aneurysm in a case of syphilis. Descending or abdominal aorta, these are all the classical lesions. Atherosclerosis. Coronary arteries, most important culprit will be the thromboembolus. Sometimes there can be an aneurysm in a case of a myocarditis. What do you see in the right atrium? What do you see in the right ventricle? So these are the things that I would like you people to kindly remember. The list is not complete. And it goes on the left side also. Left atrium, for example, there is a McCallum's plaque. What is the disease? Where do you find it? It is a case of rheumatic heart disease. Myxoma again is more common in the left atrium. This entire panel of list, I want you to people to by heart, and by heart. After all, this is an autopsy of the heart. So earlier this used to be Herophilus, an outlander anatomy. Maybe it is described as a crude method, but then today those people have taught us. The dead have taught the living. I would very firmly advise you people to kindly go to my classes in R.A.T.S, the UG. I know what kind of a stress the exam pages will be under. So go through infective endocarditis, aneurysms, atherosclerosis, rheumatic heart disease, pericarditis, and myocardial infarction. Go through all these classes. They are ready-made classes in which I would have shown a good number of pictures and given you an excellent source of theory. It might be for undergraduates, but if you answer that much, you are excellent. The next part of it shall tell us all. Thank you.